Boleh. Nah. Oh, boleh sudah. Okay. Boleh. Hello. Okay. Okay, dengar ya semua. Assalamualaikum, selamat pagi, salam sejahtera kepada semua pendengar-pendengar CME yang mendengarkan CME pada hari ini. CME kita pada hari ini akan disampaikan oleh Dr. Arun Kumar, anak lelaki Mahadevan, Pegawai Perubatan UD 43 daripada Jabatan Psikiatrik, dengan tajuk CME-nya pada hari ini, Major Depressive Disorder. Jadi kita ada masa masa lagi, jadi kita akan bersama-sama dengan Dr. Arun sebentar lagi ya. Untuk itu Dr. Arun, saya harap doktor sudah bersedia ya untuk sesi CME doktor pada hari ini. Dengan itu dipersilakan ya doktor. Terima kasih.
Okay, terima kasih Puan Laila untuk introduction tadi. So, selamat pagi semua. Terima kasih kerana sudi untuk join sesi CME ini yang saya akan sampaikan yang bertentang Major Depressive Disorder. So, nanti throughout this presentation nanti saya akan cakap celah bahasa Melayu dan bahasa English. Okay, so kita mulakan ya. So presentation ini is going to be based mostly from our CPG, Management of Major Depressive Disorder, the second edition, released in 2019. But it will be more focused on the general treatment for adults with major depressive disorder. Won't really touch on MDD in special populations lah, such as elderly or pregnant, because the I'm going to present can be applied mostly to everyone. So before we can talk about major depressive disorder, I think it's good to know what is the definition of mental health. So mental health is a state of well-being where the individual realizes their potential, their potency, able to cope with normal life stresses, work productively, and contribute to the community. So this is a state of good mental health, whereby an individual realizes all these four points. Whereas in mental disorder, it is a syndrome of clinically significant disturbances in a person's cognition, that means thinking, emotional regulation, or behavior that reflects a dysfunction in the either psychological, biological, or developmental process underlying mental functioning. So it's a very complex thing in the sense that it has to do with a lot of different factors of a person. So not just one thing, one part of it is affected that will cause a mental disorder, such as poor thinking or just feeling really sad. It has to do with a lot of different symptoms that's categorized as a syndrome, which we'll take a look on later. So that begs the question, what is MDD? What is major depressive disorder? So it is a chronic mental disorder that causes changes in moods, thoughts, behavior, and physical health. And it's also a very common illness, but at the same time, a very serious illness that can take away a person's ability to enjoy life and cause a decline in capacity to undertake even the simplest of daily tasks. And what's unfortunately, the symptoms associated are also often recurring and life-threatening. So MDD is a mental illness, but in its most severe form, it can cause a person to have their life threatened, either through very, very disturbed behavior, such as refusing to eat, which can lead to malnourishment and eventually death. Okay, so just a few statistics about major depressive disorder. So MDD is often chronic and non-recurrent, with the consequences experienced over the entire lifetime. And the prevalence of MDD in Malaysia is around 6 to 14%, with a slightly higher ratio in elderly, around 6 to 18%. Of course, when you talk about MDD, it goes almost hand in hand with suicide rates. So suicide rate in Malaysia is around 6 to 8 per 100,000 population per year, with a current rising trend. So that trend is still being more or less investigated, but there's so many postulated reasons. Our economy, inflation, work-life balance being affected. In terms of gender, there is a predominant skewing towards women who experience MDD more, but there's a significant portion of men who experience MDD as well. So maybe this number just reflects how our gender biases, whereby it's maybe okay for women to express sadness and seek help, but whereas for men, it's where maybe most men are brought up to conceal their emotions and hide their suffering. For the global prevalence of MDD, it's around 4.7%. So looking at that numbers, it seems that Malaysia has more of a higher rates of depression, MDD, compared to the world. And the World Health Organization also lists suicide as the second leading cause of death for 15 to 29-year-old. And it's estimated that by 2030, MDD will contribute to the highest burden of disease. So a mental illness causing the highest burden of disease. So that is why I think it's important for us to understand it today, so we can detect it early and give the treatment to those who need it. So, okay, this is a mental illness, but why doesn't this MDD happens in people? So, like most mental illness, the exact pathophysiology is unknown. Just because of the nature of how the symptoms come about and the circumstances which they come about. So many different reasons can trigger MDD. So the theories that are proposed is such as faulty neural circuitry. So there is some kind of brain abnormality, some kind of physical brain abnormality that is causing this. Faulty stress response, which is also related to brain, our HPA axis. Also the psychological aspect of it as well. So genetic vulnerability and environmental interaction. So in most mental illnesses and especially MDD, there is a genetic component. So uh, first degree relatives with a mental illness such as MDD tend to have higher rates in the first degree relatives. And as the relatives get more spread out, the risk decreases. So like a father with MDD might have a child with MDD, but that same father who has like a very distant cousin, there might be a risk, but it's substantially lower. However, just because you have a direct family member that has a mental illness such as MDD doesn't mean that you will get it, because it's a very complex thing involving genetics, the environment, stresses, which we'll go on to see later. But you have to bear in mind about this possibility. The thought is the biogenic monoamine theory. So at first it was postulated that there is a chemical imbalance in the brain that causes the depression to come. So that's the basis of most of our medication. But as we discover later, it's not just the neurotransmitters that are deficient, but also the receptor expression and the secondary messaging signals that accompany it. Not very important, but if you ever have to explain to one of your patients why doctor, kenapa doktor saya dapat depression ini, so you can say it's fairly justified to say that there might be some chemical imbalance in the brain as a result of all your stresses and environmental factors, and that's the reason why you can help with medication. Inflammation, some noted that in some studies where patients with depression tend to have higher inflammatory markers than the normal population, but it's yet to be determined whether that is the cause or it's like as a result of MDD. So causation is not correlation in this aspect. Hormone effect. So actually hormone is one thing that is very, I would say, have a great impact on those having MDD. It's well known that patients with, for example, thyroid disease, hypothyroidism to be specific, tend to have symptoms that mimic very closely to depression. So in our setting, as we learn later, taking a thyroid function test for all patients with depression is a very useful screening lab to ensure that the cause of the depression is not organic. And also hormones tend to fluctuate very greatly in certain populations, most specifically pregnant patients. So a pregnant woman will have so many different hormone changes throughout their pregnancy, and this can predispose them to depression. And the depression can happen anytime within the pregnancy as well, either during pre-birth, then prepartum, peripartum, or postpartum. So that's why screening for depressions in pregnant patients also is a very important thing. And then lastly, faulty circadian rhythm. So a person who is working hard, working at odd hours, not getting enough sleep, also predisposes them to depression. And the medication that we can give to help correct that also supports this theory. But like I said, the exact pathophysiology is unknown. You can see there's many different factors. And so our current understanding is it's basically accumulation of different things just happening just at the right, not say the fortunate time, but just at the right exact moment to cause depression. So it's a collection of different factors causing one final endpoint. Okay. So so we move on straight to more of a clinical sense. How do we assess and diagnose patients with MDD? So when you're seeing, especially like for example in your clinic settings, probably not in psychiatry but in other departments, it's hard to detect MDD sometimes unless you really go into it. This is just an example of the few high-risk individuals that are more prone to major depressive disorders. So that's divided into biological, psychological, and social. So patients with first-degree relatives with history of depression, like I said, more predisposed to getting MDD. Those with substance abuse, chronic diseases or pain, such as chronic back pain, or those with ERs like end-stage kidney failure, those who have very prolonged chronic diseases, those are very highly likely to get major depressive disorder because, of course, when you get a chronic disease, you have so many other aspects of your life change. Maybe you cannot stop working, you're not as mobile, you cannot do what you used to do. This all can contribute to getting MDD. Sleep disturbances, pregnancy or postpartum, obesity, old age, and especially when a patient comes with very multiple vague symptoms and then done all the organic workup, but still can't really pinpoint. So once you encounter a patient with that kind of risk factor, maybe you should consider it might be something psychological going. All right. Then, of course, experiencing any major life changes, such as marriage, loss of a loved one, recently getting a new firstborn child, anything that causes a market shift in your lifestyle. A loss of interest in sexual activity, that's also frequently underreported sign of depression. From social, maybe financial constraint, impoverished home environment, and as well as socially isolated. So we humans are a social creature. So always having a group of friends or frequent social interaction is always good. And the social interaction, mind you, doesn't have to be physical. Calling a loved one, having a good quality conversation with a loved one once every daily or a few times a week is also proven to help improve social life of a person and then reduce their risk to MDD. Okay, so so when you encounter this sort of high-risk patients, what do you ask? How do you ask someone who is depressed? Do you just straight, oh, do you have depression? Sometimes they would say yes, but these are the questions that I would say is a very short, simple screening question called the Woolley questions. So the Woolley questions actually just these two questions dalam sebulan ini. Dan sebulan yang lepas, adakah anda merasa murung, sedih atau tiada harapan? So that is a very simple question to ask, and it's known that the other question is dalam sebulan yang lepas, adakah anda kurang minat atau keseronokan dalam melakukan kerja-kerja? So these two questions are, have you been feeling depressed, sad, or hopeless? Or have you been feeling less enjoyment or less interest in doing your daily activities? By asking these two questions, you have has a sensitivity of up to 99%, but only a specificity of 78%. So the additional question of kamu perlu bantuan increases the specificity to 95%. So these three questions can help you quickly gauge, is the person depressed? Do they require further treatment? But who do you ask to? So anyone with those high risk factors, and anyone you suspect that might be having depression, or anyone who has a history of depression, or anyone who has a chronic physical health problem, or anyone who has a functional impairment. So these questions for these people are very important to make sure you don't miss the diagnosis of depression. So once you ask these questions, let's say they say yes to all these three questions. So what do we do? So we can further explore by using a few screening tools. So when it comes to screening tools, there are two types: the self-rated, which is the one that the patient fills themselves, and clinician-rated, which is performed by a health professional who is trained in using these screening tools. So for self-rated, the most common that we use is the PHQ-9, Patient Health Questionnaire 9. Next would be Back Depression Inventory, BDI, and also Depression, Anxiety, and Stress Scale. So these three have all validated Malay versions that you can find in the CPG. In terms of differences, there's not much. The differences in terms of what the questions are asked. So the PHQ-9 mostly asks very direct questions of symptoms of depression in accordance to the DSM-5. Back depression is more varied. The questions asking more regarding the intensity, and thus in addition to depression, also ask about anxiety and stress. So keep in mind when you give a person a self-rated questionnaire, depending on a person, they might tend to overrate or underrate. So the purpose of the screening tool is not to diagnose; it's more of a supplement to your clinical judgment and clinical examination, just to gauge how severe the depression is at that time. For clinician rated, is for those who have no experience, is probably not recommended to do. So it's probably safe to just do the self-rated, just to have a bit of a gauge of how severe the person's depression is. Okay. So you asked the Woolley questions, you did your screening. Okay, my screening says that this is quite high. So is it just like that? Do we just stop asking questions there? No, we have to further explore. So we have to do a proper assessment of the depression. And depression, like with any illness, it involves 4 different stages. So the first will be, of course, history taking, a very detailed history taking, physical examination, and mental state examination, as well as investigations were indicated. So I'll go by one. So, okay, so for history, when we ask about history, we have to, any of the symptoms that the patient complains, we have to ask quite detailed in several things about that symptom. So we ask, what are the presenting symptoms? How is the mode of onset? It's very different. So depression, as we know, is a chronic onset. So, well, if it's something that's just happened very acutely, broke up with your boyfriend, and then suddenly you feel all the depressive symptoms came, that is, I want to say it's not 100% not depression, but it's something you have to consider. Maybe this is not depression just yet. Maybe it's just like a very acute reaction, acute stress reaction is another thing you can use to a certain event, or or is that a normal reaction? So sometimes, how do you differentiate what normal sadness from depression? As you go to later, different has many different diagnostic criteria, but one of it would be the mode of onset. So something that has been happened just like for one day doesn't really point to depression, but something that's been going on for probably 2 weeks and more, for months, sometimes even years, then you have to ask further lah. And when those symptoms come, how frequent are they? Is it just once a day or once a week, or is it something that's been happening? The patient says, oh, happening every day, constantly, never going away. Or even if it does go away, it's maybe just once or twice a month. So that is more indicative of depression, as well as the duration and the severity of symptoms. Uh, and also you have to try to explore whether this symptom that's happening right now, is it something that happening in this one episode? So that means it started 3 weeks ago until now. So that's like one episode. So before 3 weeks, was there any other symptoms such as this? And they said, no, never. So in your entire life? No, never. All right. But then if they ask, actually, I had something like this like 2 years ago. It was around for a month. I didn't seek any treatment, but it kind of went away by itself. So that means that there's a possibility that patient already had an episode of depression, maybe not too severe, was able to resolve spontaneously, but now having a recurrent episode. So that means there's a higher likelihood this patient is uh, more predisposed to getting depression when they are faced with a certain stressor. And if the patient already had a known case of depression, has been tried on medication, it's very helpful to know what the medication was and how was the response. Um, Patients who tend to respond good to a certain type of medication tend to respond equally as well to that same medication later on. So having this information is very, very valuable to us doctors who are treating them, as well as any side effects. So as we learn later, some medication respond good to some patients, some complete opposite. So knowing what medication has been already tried and what works, what doesn't work is very, very helpful. And also, there are some studies that say that if there are family members with the similar illness, like say a father with depression and there's a son with depression, if the father has a good response to this type of medication, there is some evidence to say that using that same type of medication for the son might be beneficial as well. But again, it's all based on the individual. Also, any previous hospitalization. So patients who have been admitted before for whatever reason, tends to show that the severity is far worse. So that's something to keep in mind when evaluating the patient. Explore any recent psychosocial stressors. So instead of treating just the depression medication, we have to find out what was the triggers and uh, explore how we can change it up later on. So this all comes only after asking many, many questions. So sometimes the psychosocial stressor won't be very clear. Maybe for whatever reason, the patient is quite hesitant or guarded to give the history. But later on during subsequent follow-up, we can explore more. Okay, as like I said, family history also is very important, as well as suicide attempts. So that goes without saying, those with depression with suicide attempt is more or less higher risk than those without. Okay. So I just highlighted a bit. I need past history of manic or hypomanic episode. So this is important because major depressive disorder is illness of itself, but we also have another illness called bipolar disorder. So bipolar disorder is a disorder where a person has a history of a manic episode or a hypomanic episode, uh, but sometimes when they're first presented, let's say the first time you're seeing a patient, they don't present with this manic or hypomanic episode. So they come with the depression straight away. So when you see a patient with depression, it's always good to ask questions regarding the manic or hypomanic. Manic means basically increased self-esteem or goal-directed activities for past 1 week. Hypomanic for past 4 days. The time when a patient seems very happy, very talkative, full of energy, more than usual. So this is a sign that patient might not be having actually just a major depressive disorder, but actually having a bipolar disorder, but currently in a depressive episode. So this is important to ask because one, it's been shown that patients with bipolar given antidepressants can trigger a manic episode, and as well as patients who has bipolar with MDD, giving antidepressant is not actually the correct treatment. The treatment for bipolar depression is very different from regular depression. So asking a few questions regarding in their entire life, has there any been any state of when very happy or feel very energetic and very suddenly had a lot of plans, want to do a lot of different activities, almost not completing one before moving to the next. That all is very beneficial, just to make sure we're not missing the bipolar disorder. Of course, I have to ask any substance abuse or any psychiatric illness. So substance can affect people in many different ways. It can cause depression as well, especially those with maybe substance abuse disorder, those who are dependent or addicted to the substance. Social history and social support. So we like to know not just the patient, but the people around the patient, how the people around the patient affect the patient. Do they help the patient when she's in trouble? Can they help? Are they the supportive type, or are they maybe one of the core reasons of them getting depression? Very overbearing parents, or very stressful workplaces. That all has to be taken into account when taking the history. So as well, social and occupational impairment. So how, when the patient is having the depression, how severe are they, like impaired in terms of functioning at home? Are they able to still, bathe, dress themselves, get up in the morning, do their house chore, go to work as normal, or are they unable to do that? They just lie in bed the entire day, or they go to work, but they just sit around not doing anything. So these all are very relevant to understand the severity of the depression. And of course, any relevant medical history and drug history, because as I said, these two there are many physical illnesses and drugs that can induce depression as well, such as hypothyroidism, as I gave earlier. Okay. Okay, so for mental state examination, so this is what when we first psychiatrist, this is one of the things we do. But it's not it's a skill that has been done through many practice. But basically, in the mental state examination, we want to observe these aspects in the patients. How is their appearance? How is their behavior? A person who is mentally at that time well and no issues, they probably feel just normal, sitting properly, good eye contacts, smiling, responsive to questions, cooperative. However, a patient with depression might appear very poor eye contact, always looking down, um, might their appearance might be disheveled, not really good hygiene. They might be very guarded to talk to you, don't really explain much. That's how they might appear as a person who is depressed. And their speech might be very low tone, very monotonous. Um, uh, Sometimes, mostly they are coherent irrelevant because they're not psychotic. They're still, have intact reality testing, but maybe the speech is just qualitatively different from others, from those with no depression. So mood and affect. So mood and affect is what it means is you ask the patient the mood. So it's a direct question. This is the patient's subjective feeling. So apa perasaan kamu? Apa mood kamu? So they said, oh, mood saya sad, atau can be also empty, uh, uh, kind of mood. And the affect is what do you physically see. So as a patient appear, a patient who appears to say they're sad and then they look down and they frowning, then okay, it's a congruent to their mood. It's appropriate. So they say they're sad and they look sad. But if a patient says, "Oh, I feel sad," but then they're smiling at you, laughing, so that is an inappropriate effect. So when you have an inappropriate effect, you might have to consider something else other than just a major depressive disorder. Could be major depressive disorder, but already might be having maybe some psychotic features or some manic features as well. So for perception is mostly the hallucinations. So hallucinations, there's they all have to do with our senses. So, but the most common would be auditory hallucination. So, an auditory hallucination is very specific. If a patient says, a patient with depression tend to have a lot of negative self-talk, a lot of negative thoughts in their head, but it's in their head. So sometimes you say, "Oh, I'm hearing voices," but then you ask further, "Do you hear the voices like how a person speaks directly to you?" It's like, no, it's actually just a lot of voices in my head. So voices in your head tend to point towards more of a pseudo hallucination, more of just a lot of negative thoughts rather than true hallucination, where it's a very specific, it's an objective area, it's not voluntarily, cannot be controlled hallucination. So that's very important to us because uh, those with already very true hallucinations tend to show more severe form of depression already. So thoughts tend to involve any delusions. Sometimes in depressive disorders, the most common delusion is like delusion of nihilism. They already feel that they're very very worthless, that they're not meant to die, or they feel that their feelings of guilt is so severe they say that everything wrong in their world is because of them. So that's also something that we have to explore. Risk assessment, I'll go on later, but risk assessment basically if there's any suicidal risk uh, or homicidal risk in the patient, and it should be done for all patients. Next is the cognition. So cognition tends to involve many things, but generally it's about orientation. So are they oriented to time, place, or person? Memory, can they remember things in the short term and long term? Attention, and general intelligence, as well as judgment and insight to their current condition. So why we have to do this, just to make sure there's no other aspect of the patient that we're missing. So there's sometimes in patients, very elderly patients, they might come with kind of dementia symptoms. However, when you explore further, it's actually having depressive symptoms. So sometimes assessing their cognition can help to differentiate a true dementia with a pseudo dementia. But I won't get into that too much. Yeah. So most of the time, patient with depression, their insight is still fairly good, especially if they come and seek help by themselves. So they know that there's something wrong. Um, depression patient with no insight, that means maybe very severe, have to be brought by family refusing to eat. So those kind of poor insight depression patients tend to we have to be more careful. Probably needs more aggressive treatment. Okay. So these are just examples of the mental state. As I say later, not really going to go into that. Okay, so for physical examination, so there is no physical findings that are specific to major depressive disorder. The physical examination is still needs to be done, but to rule out any medical or surgical causes. So, like I said, um, physical illness can mimic depression sometimes. Sometimes that is the only symptom. A patient suddenly comes with the very common depressive symptoms, uh, and there's appears to have no other like physical complaints. But that might just be how the physical illness manifests itself. Especially if the depressive episode is someone who has never had depression, maybe at quite a old age, no stresses, nothing, no reason for them to be psychologically affected. So you have to always have to make sure there's no physical illness. So of course you can, this is not a very thorough list, just a few examples. So like infection, so sepsis, patient with sepsis can become very lethargy, unable to move, unable to work, unable to eat. So that has to be ruled out. Medication, certain antihypertensives, such as like, I think beta blocker, steroids as well. Steroids can also induce psychosis in certain patients. Interferon is mostly used in cancer treatment. So sometimes you have patients who start their chemotherapy, they develop depression after that. So you have to look back and see what was the chemotherapy that was given. If it's interferon, then there is a high likelihood that is the causative factor of the depression. Endocrine disorders, like I said, hypothyroidism as well as Cushing syndrome. Tumor, brain tumor, of course, depending on where the tumor is. It can affect a person's behavior and psychologically in various ways, and one of it would be depression. Certain neurological disorders, such as, like I said, dementia, Parkinson's disease, traumatic brain injuries, can all cause that. And also, I just want to highlight stroke. So, post-stroke depression is a very well-known illness, and it occurs quite regularly. So, if there's any patient you see just having stroke, in addition to their physical rehabilitation, it's also it's very useful to always screen and ask them if they're having any depressive symptoms, so that we can tackle it early on. And then finally, autoimmune, such as multiple sclerosis and systematic lupus erythematosus, SLE. So these are just a few examples, but in general, any patient first contact with depression needs to be examined thoroughly. In addition to the very thorough history taking, a very thorough physical examination is equally as important. So laboratory tests may be required. Usually, it's for all patients we take the baseline investigation, but the emphasis if the presentation is very atypical. So, in addition to the depressive symptoms, there's other symptoms that suggest a medical cause. Elderly patients, a first depressive episode, then more than 40 years old. Like I said, absence of any precipitating factors. So there's no obvious reason why he would suddenly be depressed. And a depression that's not responding fully to the standard treatment. So you've been trying on different antidepressants, always very easily get side effects, have to change, and then you start a new one and got another side effect, or you increase and there's no response. So you have to really think. You have to, at that point, you have to look back in the entire case note and go one by one. Okay, what has been done, what hasn't been done, and then investigate further. Okay, so just a few what an investigation should take. So for baseline investigations, usually it's a standard FBC, RP, electrolytes, LFT, thyroid function, fasting blood glucose and lipid profile, and ECG. So okay, FBC is just to make sure that's not missing out any anemia. RP and electrolytes, make sure not missing out any electrolyte imbalance that can cause depression. LFT is also just to make sure the liver function is normal, but also because many of the medications we use require metabolization via the liver. So if there is any evidence of liver impairment, we have to be very careful with the medication we use. Thyroid function, like I said, to make sure there's no thyroid disease, as well as blood glucose and lipid profile, because as some medications can also cause weight gain and metabolic syndrome. So monitoring that is very, very important. And ECG is just to make sure that there's no arrhythmia. Certain medications, if used, can have some unnecessary cardiac burden. So having a baseline ECG for all patients is very, very important. And in addition to that, it's just to make sure there is no arrhythmias that as well can mimic the depression. So a few more suggestive investigations. So if the history and physical examination is suggestive, you can order an iron study, vitamin B12 and folate, and effective screening. So obviously iron studies because of anemia. Certain vitamin deficiency can also mimic the depression, and it's treatable. And effective screening, if there's any history that might be suggestive of like high risk behavior or high risk occupation, then consider that as well, because the sexually transmitted disease can have many different manifestations. So finally, if the predominant symptoms is like severe fatigue and general malaise, then have to probably consider something more less common, such as EBV serology, any autoimmune serology, CRP and ESL, just to make sure there's no like any subsyndromal autoimmune disease. Okay, so for diagnosis and assessment of severity, so for depression is not something we just diagnose by just asking, oh, are you depressed? Oh, and you're depressed or you're depression? No, it has a lot of different specific symptoms, criteria, and duration. So the two Bibles, we call it, to diagnose depression is either the ICD-10, Classification of Mental and Behavior Disorder, or the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. So this is the one that we use more widely locally. However, in other countries, ICD-10 tends to be more preferred, ICD-11 actually. So I'll be discussing about the criteria in the DSM-5. And based on DSM-5, it's a minimum of 5 symptoms is required to diagnose MDD. So, right, so this is, I think, try to summarize all the symptoms into this one slide. So basically, to diagnose someone with MDD, I must have either the 2 core symptoms, which is highlighted in red, so low mood, or diminished interest or pleasure in all or almost all activities. So these 2 core symptoms have to happen most of the days for 2 weeks, for 2 weeks continuously. So that is the time, the duration we set. Okay, this person might have most likely have depression. So either one of those core symptoms, in addition to the 8 other symptoms. So there's a mnemonic for this, which we call SITCH caps. So if there any time you can remember, or you have no DSM-5, you can remember this mnemonic, so you can help you remember what questions to ask. So we go one by one. So sleep. So if there is insomnia or hypersomnia, keep in mind all of this should be happening most of the days, not just 1 or 2 days, but most of the days. So if there insomnia, difficulty to sleep, or there's too much sleep, that's a symptom. Interest, like I said, less interest in pleasure in doing all or almost all activities. There's a feelings of very worthlessness or excessive or very inappropriate guilt. There's energy described as very always fatigued, or there's a loss of energy. Concentration, so very at work or at home, it's very difficult to think, to concentrate, very indecisive, not sure what to do, or want to do something, it takes a lot of time, more than how it used to be. There is changes in appetite, either significant weight loss or weight gain, or decrease or increase in appetite. Psychomotor agitation or retardation. So others, it's observable by others, so another family members who say, oh, baru-baru ni macam sangat slow lah doktor, semua benda buat sangat-sangat lambat, cakap-cakap lambat, jalan-jalan lambat. So that's might be indicating of one of the depressive symptoms. And as well, of course, suicidal thoughts. So recurrent thoughts of death, not just the fear of dying, but actually just thinking about death, and recurrent suicidal ideation without a specific plan, or a suicidal attempt, or a specific plan. Okay, so one of the core symptoms with another 4 of these symptoms, very suggestive of depression. So, but just because we have these symptoms, it has to include a clinically significant or distress or impairment, either social, occupational, or other areas of functioning. It's not attributable to any other physiological effect of a substance or another medical condition. So, and not better explained by any psychotic disorder, and there's never been a manic or hypomanic episode. So this is all important because if it does not cause clinical distress or impairment, might be either very mild form depression, or maybe it's not depression, it's something, another diagnosis such as adjustment or what. Not attributable physiological effects. So of course, you have to make sure there's no substance, no medical condition. Make sure there's no psychotic disorder such as schizophrenia, and make sure there's no manic or hypomanic episode, because that would be bipolar. So once you've ruled all of this out, then only can confidently say there's depression. So for diagnosis, assessment of severity, so the severity of depression determines the mode of treatment, and the way we classify the severity is by the total number of symptoms, the severity, and the extent of functional disability. So for mild, there's at least 5. However, the distress is more or less manageable, and there is some impairment, but not too bad. Like patient's still able to do most of what their work. However, in severe, patient has most all the symptoms, very difficult or unmanageable, and then very marked impairment. And like I said, if there's already psychotic symptoms, so that's already a very severe form of depression. Whereas moderate is a sort of a mixture in between two. It's quite not very specific. Probably has like most of the symptoms, but still manageable, and maybe marked impairment, but not too severe. So it's in between minor and marked. So that's how we assess whether it's mild, moderate, or severe. Next, for all patients, we have to do a suicide risk assessment. So this is important in the comprehensive management of MDD, and we have a few guidelines on that, such as the Malaysian Guidelines on Suicide Prevention, and the Management and Guidelines on Suicide Risk Management in Hospital. Let's go a bit into this, because I think it's quite important for us to know. So we have to know a few terms. So there's suicidal ideation, which is the thoughts or serving as the agent of one's own death. So patient thinking about it, or thinking about killing themselves, thinking about how nice it would be to die, and maybe already thinking about, oh, what are the ways I can die, what are the things I can do. Having these thoughts of it, that's the ideation part. However, just because you're having thoughts doesn't mean, if you ask the patient, are you very intent on killing yourself? They might say, no, I'm just having these thoughts. So that's very important. So suicidal intent is the subjective expectation and desire for self-destructive act to end in death. So a person with a lot of very high intent, like, yes, I want to kill myself, that is a very high risk station that has to be closely monitored and admitted if needed. However, if you ask further, a patient with maybe come with a lot of cuttings on their arms, they ask why they do that. This was an intent to die because of cutting your arm. They might say, no, I just want to do it because I like the feeling. So that is not a suicidal, like an injury with the intention of suicide. It's actually a non-suicidal self-injury. So it's a very direct, deliberate destruction of one's own body tissue without any intent to die. So that's why when you see the action, it's always very important to ask about the intent. What was the intent? Did they want to die, or did they just do it for other reasons? Maybe to release stress, or so on and so forth. So for the factors that need to be assessed in a suicidal patient is called the current mental state, and talk about death and suicide. Current suicide plan. What is the seriousness of the intent? The methods, any planning they've done, any preparations they've done, is this something they've been thinking for weeks and been planning meticulously, gathering items, writing suicide notes, or is it something that they were scolded by, or they broke up with their boyfriend and the next day they did it? Something quite impulsive. So that's very important as well. As well as the person's support system. So patients who are maybe like moderately suicide, there is some risk, but if the patient's family and friends are willing to monitor her 24/7, then that also helps in our management. So, like for depression, there are a few screening scales. For suicide, there's a few risk assessment scales as well. So among those mostly used is the sad person scale, the suicide assessment 5-step evaluation and triage, or safety, and the Beck's suicidal intent scale. So if you don't know what to ask when you see a patient who's suicidal, it might be very useful to have these assessment scales to ask the questions from this. But it's not understand this is not used to determine your management. It's not, oh, the scale is low, so you can be discharged. No, it shouldn't be used alone to determine treatment or predict the future risk of suicide or self-harm. It must be used in conjunction with a good clinical assessment, as well as building a good therapeutic alliance with the patient. So this is just a guide of how you might want to manage, but in the end of the day, it's your clinical judgment. But it's very useful to see this because the questions in this are very, very detailed, especially the Beck suicidal intent scale. Each question is very, very specific and can really give you a good, clear picture of what the patient's thought process is in regards to their suicide action, their attempt. So these are just a few of the risk factors with suicide. So there's a kind of history of suicide, there's a very severe depression, there's a past suicidal stand, there's a loss of self-esteem, recent loss of a relationship, other comorbid medical conditions. The patient is very agitated when you see him, having a lot of suicidal ideation with very high intent. Hopelessness, if patients say they're just hopeless and give up, that's actually a very, very important factor. So we always ask the patients how hopeful they feel about the future. Any current financial or occupational difficulty, any alcohol or and abuse or dependence, as well as how is the social support. So these are some of the risk factors you must consider when managing a patient with suicide. Okay, so go back to MDD. So what's the criteria for referral to psychiatry? So if the patient is quote-unquote unstable, then emergency department would be the right choice. However, the patient is more or less stable, not very actively suicidal, still functioning well, then we can visit outpatient psychiatry clinic. So some of the indications is of course attempted suicide, actively suicidal, having the psychotic symptoms, very agitated, self-neglect, not eating, not taking care of himself, or you try to manage in your outpatient, but unsure of diagnosis, there's clinically getting worse, there's more than one episode within a year, already tried treating, but there's failure of treatment, or just unsure and they want further advice on treatment. So sometimes outpatient treatment is not enough. So there is of course possibility to be admitted lah. So admission will be either voluntary or involuntary according to the Mental Health Act. So it's for psychiatry it's a bit different. This is very legal admitting a patient because they're admitting them, especially if involuntary, against their will. So the indication for admission would either be there's a risk of harm to himself or to others, the psychotic symptoms, the severe self-neglect, or there's a lack of impulse control. So unable to stop, the patient feels like unable to stop the intention of harming themselves or others. Okay, so present time, I'll just go by a bit quickly. So for treatment, so the general principles of MDD treatment is to relieve symptoms with the aim for remission. So completely no symptoms, that is our aim. If we have a patient with cheating, it's still not fully remitted, we're not doing something right there. We try to aim the patient to feel as 100% well, as well to reduce morbidity and disability, and to limit risk of self-harm and fatality. So there's four modalities of treatment, the 4 Ps. So psychosocial intervention, psychotherapy, pharmacotherapy, and physical. Okay, so the phases of treatment is usually the acute phase, which is less than 12 weeks, the first 3 months after the patient developed the symptoms and came to us at the peak of the symptoms, and when we start commencing the treatment lah. After that, it will be in the continuation and maintenance phase lah. So anytime in between, there might be remission, there might be relapses, or the patient might recover for many years and then they have a recurrence in the future. Okay, so for first psychosocial interventions, so this is something most people can do without any background in psychiatry as well. So psychoeducation. So psychoeducation is just explaining to the patient about depression. So explaining what I explained just now can be explained to them, for them to have an understanding about what the disease is, why it happened, what are the symptoms, how long will the symptoms be, etc. So just explaining the patient about the depression is shown to help them feel more comfortable, relaxed. Sometimes just knowing that I'm not quote unquote crazy, I'm just having an illness can be therapeutic to the patient. Sometimes when the depression is not too severe, it can be might not even need a psychiatric referral, but just a counselor referral. So counselors normally use what we call supportive psychotherapy, non-directed supportive psychotherapy, just to help patient work through their problems. Peer intervention, such as peer support or self-help groups. Unfortunately, in Tawau, there's not that many, but in other centers in Kuala Lumpur, there's a few of these support groups for depression. Psychospiritual intervention, so this depends on the patient. Some patients maybe have a very strong religious component to their personality, and tackling depression via prayers and visiting like maybe the ulama or the priest can help with the depression, as well as teaching them relaxation technique such as progressive muscle relaxation imagery, autogenic training. So if you're not sure how to do it, you can always refer to the occupational therapist for them to help teach the patient. And finally, another one is exercise therapy. So I just want to highlight this because exercise has been shown time and time again to improve a patient's mood significantly in many different settings. So always ask patients, are they exercising regularly? Sometimes exercise itself can help improve the symptoms quite drastically. So an exercise therapy is already planned, structured, repetitive bodily movement. So around 45 to 60 minutes per session, 3 times a week for 10 to 12 weeks. So the mechanism exercise either might include positive feedback from others, increase sense of self-worth, and diversion from negative thoughts, increase social contact, as well as the changes in endorphins and monoamine concentrations. Okay, so psychotherapy is a talk therapy. So this is what people think when they say they're seeing a psychiatrist, sitting on the couch and telling your problems. However, it's not a simple, it's something like that, but it's basically trying to help patient tackle the depression from a psychological standpoint. So as you see a picture here, trying to unravel the messy multiple yarns in the patient's brain so they can feel more confident, able to um, help with their depression. So there's many different types: cognitive behavioral therapy, problem-solving therapy, acceptance and commitment therapy, and interpersonal psychotherapy among the few. But it requires a trained, competent practitioner who has many years in psychotherapy to deliver this. And the type of psychotherapy depends on the patient's preference, the nature of the depression, availability of the trained therapist and therapeutic alliance, and the availability of the therapy itself. So here it's not very commonly done. All psychiatrists can do this, but yeah, it requires a bit more time and scheduling. So for pharmacotherapy, so there's basically two generations. The first generation at the bottom, you see the monoamine oxidase inhibitors and the tricyclic antidepressants, and the second generation. So there's many different types, but the one that we mostly use in our government setting is the selective serotonin reuptake inhibitors. So that's our first line, you can say. But any of this as well, the second generation can be used as first line, but depending on availability and patient's preference, as well as symptom profile. So patient profile, commitment, medication, and drug interactions, cost and availability, the patient's preference, as well as efficacy and tolerability, all you have to factor in when choosing a medication. However, in the end, um, the patient's uh, which one you want to say which is better and which is not. There is a few meta-analysis that has this result of certain medication to be effective, such as escitalopram, mirtazapine, venlafaxine, vortioxetine, agomelatine, and amitriptyline. Escitalopram and sertraline seem to be more tolerable. However, in the end, it only depends on the patient himself. So different individuals have different reaction to certain medication. So sometimes it's more of a trial and error. We give what we think works best, but if that doesn't work, we have to try other medications that's available until we find the right one. So just a quick note about benzos. So we can use it as an adjunct to antidepressant if patient with severe anxiety, agitation, or insomnia. But however, we should avoid prescribing for more than 2 to 4 weeks due to the risk of dependency. And the shorter half-life of the benzodiazepine, higher risk of dependency. Okay, so our aim is to, sorry, I'm going a fast but I think I'm lacking of time really. So the aim is for remission between 8 to 12 weeks. And so if any early improvement from baseline at 2 to 4 weeks, around 20 to 30%, that means that it more or less predicts a response and remission at 6 to 12 weeks. So after starting medication, there's really some improvement. So it might be a sign that patient is getting better with medication and it's good to continue. However, patients should be closely monitored, given TCA of within 2 weeks, especially the early part after initiating treatment, just to make sure there's no side effects and there's no suicidal risks. And then the aim of maintenance phase is to prevent relapse or recurrence. So for a patient with first episode of depression, normally it's suggested to maintain the antidepressant from 6 to 9 months after remission. However, consider maintenance treatment for 2 years or more if there's a high risk of relapse, such as frequent recurrent episodes. The episode is very severe, very chronic, presence of other psychiatric or medical conditions, presence of residual symptoms, or very difficult to treat episodes. Okay, I won't really go into this. These are just more specific investigation for each specific medication. Just must make sure that the ECG, LFTs are normal, electrolytes are normal, whole blood count is normal. Okay, so let's say a patient first episode after 9 months, they're already well. They say, okay, doctor, I don't want to take a medication anymore. So you have to advise the patient that there might be a few discontinuation symptoms with the acronym of FINISH, especially in SSRI. So it's either like flu-like symptoms, insomnia, nausea, imbalance, sensory disturbances, or hyperarousal. But and also important to know, we cannot just suddenly off the all the antidepressants just like that. However, it has to be slowly tapered down over several weeks or even months to make sure that the patient doesn't have any very severe discontinuation symptoms. And it's normally done within weeks or months, unless it's a very urgent reason, like very, very bad side effects, then only then we can consider, okay, maybe offering the medication straight. Okay, certain patients, 20 to 30%, do not respond adequately, and some might develop chronic depression in 1 to 5%. So the treatment failure could be many reasons. So it could be incorrect diagnosis, the failure to diagnose bipolar, for example. Could be a very psychotic depression. There is an organic condition that was unaddressed, and as well as comorbid psychiatric disorders. So OCD, personality, substance abuse. Okay, and the psychosocial factors and non-compliance. So for all medications, we can usually optimize until the maximum dose. If that doesn't work, we can switch it. Or if there's like a partial response, maybe we can augment it with another medication from a different class. And finally, the one we rarely do is combination therapy. Usually we just do the first three. Okay, so this is just the algorithm for the depression. It's why basically I won't really go back into it. Okay, so physical treatment for the our last resort, if the depression is not responding to medication and very severe, we need to stabilize patient quickly. It's ECT, electroconvulsive therapy. So it's a therapeutic procedure that induces seizure by applying electrical stimulus to the brain, and it's very effective for many different types of mental illnesses, including depression. So it's indicated if the patient has active suicidal ideation, very severe symptoms, psychotic or catatonic, or very rapidly deteriorating physical status. That means refuse to eat, they want to engage, want to take medication, treatment-resistant depression, very intolerant to medication. There has been evidence of good response to ECT, pregnancy, for any of the above reasons, as well as patient preference. So there's no absolute contraindication to ECT. There's just a few relative contraindications, such as space occupying lesion in the brain, increased intracranial pressure, recent cerebral hemorrhage, recent MI, vascular aneurysm, pheochromocytoma. So all of this have to be weighed for your risk and benefits for the patient. In terms of side effect, most have just some short-term retrograde and anterograde amnesia and transient post-acute confusional state, which can be lessened in unilateral ECT or lower dose or given just twice a week regime. Only the most serious complications can be like status epilepticus or laryngospasm. Okay. All right. So those are all the different modalities. So in terms of how do we treat? So basically in the acute phase, if the patient has mild to moderate, sorry, psychosocial intervention for all classes of severity is available psychotherapy. And if it's just mild to moderate, you can consider pharmacotherapy as well. If there's a past history of moderate to severe depression, patient's preference, there's a previous response to the antidepressant, or there's a lack of response to the non-pharmacotherapy interventions. So ideally, it's psychosocial intervention and psychotherapy. However, if patient and is indicated, you can start pharmacotherapy in mild to moderate as well. In moderate to severe, however, pharmacotherapy is the number one, with adjunct psychotherapy and the psychosocial intervention. However, if those three are not working, then we can consider ECT. In psychotic features, we cannot do psychotherapy in those who have psychotic features because they're not psychologically minded. So it's mostly pharmacotherapy, psychosocial intervention, and ECT if needed. And then later on, once moved out from the acute phase, we continue with the pharmacotherapy and the psychosocial intervention, or if the patient prefers, psychotherapy is available with the psychosocial intervention. So in all of this, psychosocial intervention has to be done for all patients to give them the best chance of recovering from depression. Okay, so just a few take-home messages for depression, just categorizing the 6 R's of depression. So first is to recognize the symptoms, to record a very proper and detailed history, to rule out any organic causes, to do risk assessment for all patients. Remission is our target, and if all else fails, refer if needed. Okay. All right, so here are my references. Thank you very much. So sorry, just 2 minutes over. If there's any questions, be happy to answer them. Thank you.
Okay. Terima kasih Dr. Arun. Sebelum itu, ada sesiapa yang ingin bertanya kepada Dr. Arun berkenaan topik kita ini? Boleh secara direct dengan Dr. Arun ataupun boleh melalui ruangan chat ya. Kita tunggu sebentar lagi ya Doktor.
Okay.
Ada kali kan? Dr. Arun, saya rasa macam ada satu pertanyaan di situ daripada Nurul Syakira.
Okay, yeah, saya dah nampak. Okay, is there any such thing as high functioning depression? Okay, so thank you Nurul for that question. Oh, well, if we base it on our current diagnostic criteria, there is no such formal term or illness such as high functioning depression. However, it's been known in the literature previously that there are certain people who seems to be exhibiting all the depressive symptoms, but for whatever reason, they're still able to function. However, most of the time, if you dig a bit deeper in those who have this high functioning depression, they might tend to be still working at, still able to function at work at required level. But if you ask back, okay, once you go back to work, what do you do? Then they say, oh, actually when I go back, I just feel tired. I just at home the whole day, just need to rest, have to recover, not really need to do anything. So it might be, different people have different ways to cope with mental illness. Some people, paradoxically, the way they cope is by working harder, maybe to try to avoid all the negative thoughts or the negative feeling, or try to keep themselves occupied. But then, of course, in the long term, it's not going to be able to sustain. Eventually, they'll be burnt out. Eventually, they won't be able to function in the long term. But yeah, to answer your question, it's not such a very well recognized sort of type of depression, but say it doesn't occur, I think it's not fair to say lah, because people are different. They might be those who are still able to function, but at the same time having the depressive symptoms, but much more subtly and not very obvious. So yeah, if it's important to see the whole history, not just impairment in work lah, because depression honestly is one of the it's a very kind of chameleon kind of disease, in the sense that the depression can appear in many different ways. There used to be something called agitated depression. So their symptom is not low mood, but they're very irritable, they're very agitated, they want to fight with everyone. So they might think that, oh, this person is just a very bad person, always want to fight, but actually they're depressed. But because it's not the typical depression, it tends to be missed lah. So I hope that answers your question.
Okey, terima kasih daripada Cik Nurul Syakira. atas pertanyaan tadi dan harap daripada Dr. Arun menjawab pertanyaan Cik Nurul ya. Jadi ada sesiapa lagi yang ingin bertanyakan soalan sebelum kita menutup sesi CME kita pada pagi ini? Saya rasa mungkin Dr. Arun kita tidak ada soalan lagi. Jadi saya daripada pihak unit latihan ingin mengucapkan terima kasih banyak-banyak kepada Dr. Arun sebagai penceramah pada hari ini untuk sesi CME pada hari ini ya Dr. Arun. Dan kepada peserta-peserta CME jangan lupa isi borang Google Form untuk bukti kehadiran CME pada hari ini. Sekali lagi terima kasih kepada pendengar-pendengar CME yang bersama-sama mendengarkan CME pada pagi ini dan kepada Dr. Arun, terima kasih banyak-banyak ya Dr. Arun.
Okay. Terima kasih Puan Lina.
Okay, terima kasih Doktor. Setakat itu sahaja. Kita akan berjumpa sesi CME kita pada bulan Mei ya. Jadi dengan itu saya sudahi. Sekian, terima kasih dan Assalamualaikum.